IDCCM and addict person, and is highly interested in new innovations and teachings and research in critical care. Uh, Without further ado, I'll just invite Dr. Shikha to start with a presentation. So Dr. Shikha, please you start with your topic is basics of fast drug bid.
Thank you, sir, for such a lovely introduction. I welcome you all to this step-in session, which is an excellent initiative by the ISCCM towards education and training of nursing, critical care nursing personnel. Now, regardless of the nature of the critical care disease that a patient may be suffering from in ICU, the basics of routine day-to-day care management is the backbone of patient treatment. Attention to small details, no matter how unglamorous they may seem, nothing is more important than that. And nursing personnel, critical care nurses, they are the backbone of this day-to-day routine management. Now consider this. The person who has been religiously charting heparin in order to prevent DVT, the person who has been taking care of regular posture turning to prevent sore formation, and the person who has been taking care of the Foley's catheter religiously in order to prevent catheter-associated infections. His or her job is almost as important as the job of a seasoned surgeon who has performed a complex cancer surgery in the patient, if not more. So from time to time, there have been attempts to standardize this care program and make it more comprehensive, more easy to perform, and difficult to forget. So now, in the year 2005, Professor J.L. Vincent, he came up with an excellent mnemonic or a care bundle such as FAST HUG in order to standardize this day-to-day care plan, where each alphabet of the FAST HUG, it indicated one aspect of patient care. This was the paper which he published in 2005 in the journal Critical Care Medicine with the title, "Give Your Patient a Fast Hug at least once a day." Now, this fast hug became quite popular, and in 2009, Professor Vincent and his team came up with a revised mnemonic, that is Fast Hugs BID, and with some more additions to this care plan. Now, so what essentially is the Fast Hugs BID? It is a method to assess the critical care patients effectively, cover all basic needs of the patient so that we don't miss out on any essential needed thing for the patient. And it is known to improve quality of care and to improve teamwork. Now, I'm sure most of you are already well versed with the various terms of Fast Hugs BID. We'll just quickly go through them one by one. So F stands for feeding, A for analgesia, S for sedation, T for thromboprophylaxis, H for head of bed elevation, U for ulcer prophylaxis, G for sugar or glycemic control, S for spontaneous awakening trial or spontaneous breathing trial, B for bowel regime, I for indwelling catheters, and D for de-escalation of antibiotics. Now, let us talk through each aspect one by one. When it comes to feeding, obviously, feeding is very important in critical care. And we all know that critically ill patients will not be able to signal their hunger needs to you. But we all know that critically ill patients are hypercatabolic and get malnourished very soon, which leads to a loss of lean body mass, impaired wound healing, insulin resistance, organ dysfunction, and failure to thrive. Now, because of less or obsolete feeding, there is a problem with decreased perfusion in the GI tract, which leads to a breach in the integrity of the GI mucosa, and this in turn promotes bacterial overgrowth, which can cause various secondary infections and obviously impact the length of stay in the ICU. Now, why are the critically ill patients so much at risk of malnutrition? Obviously, there are a multitude of factors responsible for this. Critically ill patients have fastly depleting reserves because they are in hypercatabolic state, and they are more often than not in pro-inflammatory states. Also, any patient who is not able to eat for more than 5 days is at risk of malnutrition. And obviously, because of multitude of metabolic factors, because of various drugs that the patient may be receiving, prolonged bedridden status, these patients have an impaired bowel function. Of course, all critical illnesses, they disrupt the supply and demand ratio. The metabolic demands, oxygen demands, and nutritional demands are increased, and it is very difficult to keep pace with these increased demands. And also, in many patients, there is a need for prolonged bowel rest, especially in post-operative cases, and all of this causes the peril of malnutrition in critically ill patients. Now, it is very prudent that all the patients admitted in ICU should be routinely subjected for nutritional assessment and for screening of malnutrition, and they should be checked regularly. The subjective global assessment is an important tool. It is in the form of a questionnaire, which is important for detecting malnutrition in the patient. This tool, in combination with other tools like anthropometric measurements, such as body mass index, ideal body weight measurement, tricep muscle thickness, subcutaneous fat assessment, and also biochemical parameters like albumin, pre-albumin, cholesterol, lipid ratios, all these should come in handy. Also, simply by applying common sense, by looking at the patient, looking at the quality of hair, quality of nails, the presence of edema, presence of ascites, all this should be able to give you a fair indication of nutritional status of the patient. Now, when it comes to feeding regime, of course, if the patient is able to take by mouth, then the patient is on oral feed. But more often than not, patients would be in ICU would be on some kind of enteral feeding, such as nasogastric feed, nasojejunal feed, and in patients of GI surgery, many patients would be on a feeding jejunostomy, and in prolonged bedridden patients who need continuous nutritional support, they may also be placed on percutaneous endoscopic gastrostomy. Also, if the patient has not been able to receive enteral nutrition for at least 7 days, sometimes it becomes prudent to start parenteral feed or total parenteral nutrition or TPN. But TPN is never the first choice in ICU because it comes with its own arrays of side effects. We all should be familiar with that. TPN can give rise to metabolic complications like metabolic acidosis and electrolyte derangements and abnormalities like hypokalemia, hypomagnesemia, hypophosphatemia, and also it can give rise to jaundice. Also, there are always chances of fluid overload and chances of giving rise to secondary sepsis. So you have to be very, very careful while giving TPN to the patient. Now, what are the feeding goals? We all know that indirect calorimetry is the gold standard for assessing the calorie needs in a critically ill patient. But we are also aware of the fact that most resource limited ICUs in our country, they do not have the setup of indirect calorimetry. So in that case, it is prudent to give around 25 kilocalorie per kg of ideal body weight daily calories to the patient, and 60 to 70% of these calories should come from carbohydrates and 30 to 40% should come from fat. Not a single protein should be driven towards meeting calorie needs, but you need protein around 1.2 to 2 gram per kg per day in order to build the muscles, in order for various enzymatic reactions and also for immune integrity. Now, what should be the nurse's role? It is important that nurses should elevate the head end to 30 to 45 degree to prevent aspiration. Prior to giving feed, check the fixation of the tube and the positioning of the tube. Also assess for GI tolerance, look for gastric residual volume. Any gastric aspirate more than 500 ml in 24 hours, you have to give some kind of gut motility drug or prokinetic drug such as erythromycin or metoclopramide, or which we know by the name of Perinom or Lesuride. And After feed, it is important to flush with normal water to prevent tube clogging. And it is important to follow complete aseptic precautions, whether you are giving enteral nutrition or parenteral nutrition. Now, analgesia is also an important aspect which needs to be tended to daily and in every shift, because more often than not, there is a complacent tendency in ICU to keep analgesic infusions running, even though the patient may not be requiring it anymore. So also there is a problem with under analgesia. If the patient suffers from under analgesia, his excruciating pain may lead to post-traumatic stress disorder, which might trouble the patient even after the patient is discharged from the ICU. So pain can be in different forms, like illnesses such as pancreatitis, or if there is an abscess, etc. in the body, or device related, such as if the patient is put on an endotracheal tube and mechanical ventilation, or the patient has an ICD in place which is giving him pain, and also due to procedures like Riles tube, suctioning, etc. Analgesia can be preemptive when it is given when you anticipate pain in the patient, such as before doing a procedure or surgery, or therapeutic, which is to alleviate pain. Now, it can also be systemic form, such as given enterally or orally or intravenous, or regional analgesia is also a technique, especially in the post-operative phase. It is important to know about that also. So what are the pros? Obviously, analgesia is essential to optimize patient comfort, to minimize acute stress response. But prolonged and unnecessary analgesia can lead to unwanted drug-related side effects, which I'm going to talk about in next slide. So what are the popular analgesic agents of choice? Traditionally, for years, opioids have been popular, such as fentanyl, remifentanil, butorphanol, tramadol, etc. And there are also some good non-opioid choices like paracetamol, NSAIDs like diclofenac, ibuprofen, ketorolac, etc. Also, as I mentioned, there are certain regional anesthesia techniques such as epidural nerve block, peripheral nerve block, plexus nerve block, where you give a calculated dose of local anesthetic agent through a continuous infusion catheter. Now, all of them have some limitations. Opioids, we know, they raise problem of GI intolerance. They can cause nausea, vomiting, gastroparesis, and decreased gut motility, which can adversely impact a recovering patient, especially a post-operative surgery patient. Also, you have to be careful when you are giving non-opioids, particularly NSAIDs, such as diclofenac, etc., because they can give rise to AKI or acute renal failure because of the property of causing analgesic nephropathy. Also, when the patient is on nerve blocks, you have to completely monitor the site, the catheter site, and look for any signs of infection, and also keep a check on the total analgesic local anesthetic dose that is being administered, and be aware of any side effects of the same. Now, what should be the nurse's role? The pain should be assessed daily with some form of scale or tool, such as visual analog scale, critical pain observation tool, or behavioral pain scale. This towards my left is the example of the VAS scale, which ranges from 0 to 10. And also critical care pain observation tool is becoming increasingly popular. It is based on 4 indicators such as facial expression, body movements, muscle tension, and ventilator compliance for patients who are on ventilator, and vocalization for patients who are not on ventilator. Now, again, just like analgesia, sedation is also very important, because the same problem, unnecessary and prolonged sedation, can give rise to multitude of issues. What is the need of sedation? It is helpful to control agitation, prevent accidental extubation, control intracranial pressure, and reduce cerebral metabolic oxygen rate, especially in patients who have an intracranial pathology or they have head trauma. Now, what are the perils of sedation? Obviously, sedation is a double-edged sword because over-sedation can lead to respiratory depression, hypotension, and prolonged sedation can lead to nosocomial infections. Now, daily interruption of sedation, something which we call as sedation hold or daily awakening trial, is becoming increasingly popular to assess readiness for weaning daily. And it is known to benefit the patient by promoting more ventilator-free days and early discharge from ICU. Now, traditionally, benzodiazepines have been the classical sedation choices, such as diazepam, midazolam, lorazepam, but they are limited by certain neurological side effects, and they have the propensity to cause delirium in ICU. So newer sedation choices, such as centrally acting alpha-2 agonists like dexmedetomidine, are becoming safer choices nowadays. And we must know about the various choices that we can offer to the patient. So what should be the nurse's role? Nurses during each shift should evaluate the depth of sedation either by Glasgow Coma Scale, especially in patients who have had an intracranial pathology or head trauma, and through Richmond Agitation Sedation Scale, especially in patients who had an intact sensorium before starting sedation. So what is Glasgow Coma Scale? It is a 15-point score which assesses the patient on 3 behavioral parameters like eye-opening response, verbal response, and motor response. Remember, the worst score is 3 and the best score is 15. Now, Richmond Agitation Sedation Scale is a popular scale. It comprises from a scale of +4, where the patient is completely uncooperative, combative, and extremely violent and poses immediate danger to staff and to himself or herself, or -5, where the patient is deeply comatose, unarousable, and there is no response to any kind of stimulation. The ideal scale in RASS should be 0 or -1. 0, where the patient is alert and calm and spontaneously pays attentions to the caregiver, and -1, when the patient is somnolent, drowsy, but has sustained awakening to the voice command. Now, another key aspect is thromboprophylaxis, and we are perhaps all familiar with the classical Workhouse triad, which promotes deep venous stasis and thrombus formation, which comprises of hypercoagulability, vascular damage, and circulatory stasis. Now, prolongation of intubation, mechanical ventilation, bedridden status can all lead to thromboembolism. It can promote deep vein thrombus formation, and it can also promote pulmonary embolism. Embolism happens when a thrombus lodged in the deep vein gets dislodged and passes through the lung and leads to pulmonary embolism and hemodynamic as well as oxygen compromise. So remember that thromboprophylaxis plan should be implemented within first 24 hours of admission. And also, if because of any reason you are not giving thromboprophylaxis to the patient, that should be carefully documented in your care plan, because it is also very important from medico-legal aspect, because if there is any potential lawsuit, you will be able to prove that not giving thromboprophylaxis was a deliberate act in benefit of patient rather than an act of omission. Now, what should be the nurse's role? The nurses should be well versed with the modified Wells criteria. This is a criteria which helps us predict that which patient is more prone to developing deep vein thrombosis. And this chart, Wells score, should be a part of the regular documentation plan in the nursing charts. Also, nurses should be well versed with various pharmacological as well as non-pharmacological modes of DVT prophylaxis. What are the mechanical modes of DVT prophylaxis? Graduate compression devices, also known as IPCs, or thigh length elasticized compression stockings. Also, there are various pharmacological choices available which are more often than not preferred, such as enoxaparin, which is Clexane, dalteparin, we know popularly as Fragmin, Fondaparinux, that is Ponderate, and low-dose unfractionated heparin. All these drugs are given subcutaneously, and all the nurses should be well versed with these drugs and the technique of correct subcutaneous administration. Now, another important aspect is head of bed elevation. Head of bed elevation helps prevent aspiration and hence prevents ventilator-associated pneumonia, and also promotes decrease in intracranial pressure, particularly in patients who are prone to developing high ICP like head trauma, intracranial pathology, intracranial tumors, and acute hepatic coma. All these patients should be subjected to head of bed elevation, and head of bed elevation is contraindicated in certain conditions like hypotension, pelvic instability, and spine fractures, and all the nurses should be aware of that, and they should always ensure head of bed elevation to 30 to 45 degrees unless it is contraindicated. Now, talking about stress ulcer prophylaxis, ulcer formation is very common in the critical care environment because the environment is such. It has been shown in various studies that critically ill patients, they suffer from stress GI ulcer, and this problem is to the tune of around 4 to 5%. What are the various causes of increased incidence of stress ulcer? Well, head trauma, burns, specifically more than 30% of the body surface area, any emergency or major surgery, severe or multi-system trauma, shock and multi-organ failure, coagulopathy, any patient who is on ventilator for more than 48 hours, ongoing therapy with ulcerogenic drugs. And remember, there are many drugs that we use in critical care that can cause ulcers, specific, like for example, ecosprin or NSAIDs, and also history of ulcer-related bleeding. Now, what are the issues with ulcer formation? Obviously, there is mucosal damage, which can often cause significant bleeding. The incidence of bleeding ulcers can range from 1.5 to 8.5%, and even in patients who have not been offered any prophylaxis, this problem of bleeding may reach up to 15%. And prophylaxis prevents stress ulcer formation in ICU. So nurses should be well versed with the problem of stress ulcer formation, and they should ensure that patient is receiving a form of stress ulcer prophylaxis, which can be in the form of histamine 2 receptor blockers like ranitidine, famotidine, proton pump inhibitors like pantoprazole, lansoprazole, esomeprazole. They are becoming a popular choice nowadays, and also sucralfate. Now, histamine receptor blockers and proton pump inhibitor blockers, they promote the prevention of ulcer formation by increasing the gastric pH. And we all know that by increasing the gastric pH, there is a problem of causing secondary infections such as ventilator-associated pneumonia. So all these drugs come with their side effects. We should be aware of that. Long-term PPI therapy can lead to metabolic problems with hypomagnesemia, hypocalcemia, etc. And a nurse should be aware of that. Sucralfate, it forms a kind of protective coating around the ulcer, and it prevents further damage from enzymes and acids. So we must be able to give some form of stress ulcer prophylaxis to the patients in critical care. Now, talking about sugar control, another very important aspect. Remember that hyperglycemia is dangerous because it can impact organ function. It can cause poor wound healing, give rise to secondary infections. But hypoglycemia is equally dangerous because it can cause neurological implications. And this was long back proven through the NICE sugar trial. So the present recommended goal is to maintain blood sugar level in not a very tight manner, but in a non-tight manner between 120 to 180 milligram per deciliter in critically ill patients, as recommended by the findings of the NICE sugar trials. Initially, when the patient comes in ICU and patient is hemodynamically unstable, you have to give short-acting regular IV infusions. And only when the patient becomes hemodynamically stable, then only in that case, you should start giving subcutaneous insulin, because if you give subcutaneous insulin in a patient who is suffering from gross hypotension, in that case, there will be problem of absorption through the subcutaneous route, and also the drug may just be accumulated in the subcutaneous tissue. Long-acting insulins and oral hypoglycemic agents should be best avoided in critical care because they can give rise to unpredictable spells of hypoglycemia. And beware that insulin, specifically IV insulin can give rise to hypokalemia. So the nurses should be aware of that, and they should know how to prepare insulin infusions correctly. Now, talking about spontaneous breathing trial. Spontaneous breathing trial is daily sedation interruption, daily sedation hold, and giving a spontaneous breathing trial in order to see if the patient is ready for weaning. And this is a proven beneficial strategy because it helps reduce the number of ventilator days and also promote early discharge from ICU. Now, there are various mechanisms and forms through which you can give spontaneous breathing trials, such as low level of CPAP, 5 centimeter of water, or through low level of pressure support ventilation, such as 5 to 8 centimeter of water, flow triggering with no pressure support, and T-piece breathing. And you have to choose either of them. Remember that spontaneous breathing trials do not guarantee that the airway will be patent and the airway will be stable and the patient will be able to clear secretions. You should give the spontaneous breathing trial no more than 30 to 120 minutes, and ABG should be obtained at the end of spontaneous breathing trial. There are various criteria for a failed SBT trial, and the nurses should be well aware of that, and they should be able to document that, such as respiratory more than 35 for 5 minutes, saturation less than 90% for 30 seconds, tachycardia, low hypotension or hypertension, sustained increased work of breathing, cardiac dysrhythmias, and metabolic acidosis. There can be various causes of failed spontaneous breathing trials like anxiety, agitation, infections, electrolyte abnormalities, pulmonary edema, malnutrition, neuromuscular disease, raised ICP, and excessive auto-PEEP generation, such as in COPD and asthma. So what should be the nurse's role? The nurses should be able to monitor the patient who is on SBT trial through subjective or objective parameters, and they should be able to document that. So if there is any agitation or anxiety, depressed mental status, falling GCS, sweating, cyanosis, or extreme tachypnea, increased use of accessory muscles of respiration, facial signs of distress and dyspnea, then in that case, the nurse should immediately inform the doctor, and in such cases, the SBT has to be terminated. Also, be well versed with objective measures of failure of SBT, such as PaO2 less than 50 to 60, and saturation less than 90%, even on FiO2 more than 50%, PaCO2 more than 50, pH less than 7.3, and rapid shallow breathing index more than 105, that is your respiratory rate becomes higher and the tidal volume becomes lower, and respiratory rate more than 35 and heart rate more than 140. So next step is bowel care. It is also a very key element of patient care routinely. Bowel disruptions in ICU can be in the form of diarrhea or constipation. Now, diarrhea is when there are 3 or more liquid stools per day or more than 250 grams of liquid stool per day. Diarrhea can lead to electrolyte imbalances and dehydration. And in ICU, most cases of diarrhea are non-infective, which can be due to a variety of causes like laxatives, if you're giving the patient lactulose or piclin indiscriminately, due to pot chlor or phosphorus supplements, or there can also be osmotic diarrhea due to hyperosmotic enteral feeds. When it comes to infective diarrhea, patient who has been in the ICU for long and who is on multiple antibiotic therapies, such patient is prone to Clostridium difficile infection, and you must keep the DD in mind. And also, treatment is not to stop feeds, but add soluble fibers and semi-elemental feed. Keep the patient hydrated. And if there is a blood in stool or you are suspecting infection, then necessary workup should be done. And you should be able to guide your doctor towards that. Now, constipation is when there is loss of bowel evacuation for 3 consecutive days. The causes can be multifold in ICU, such as the use of opioids, dyselectrolytemia, particularly hypokalemia, hypomagnesemia, hyponatremia, presence of ileus, subacute intestinal obstruction, and the rampant use of diuretics, which lead to dehydration and hard stool formation. The treatment is to correct metabolic deficiencies, correct the hypokalemia, hold the opioids, give some non-opioid analgesic regime, restrict the use of diuretics if they are not needed, and give laxative enema, lactulose enema, proctolysis enema if required. Now, what should be the nurse's role? The nurses should look for abdominal distension. They should be able to auscultate for bowel sounds, palpate abdomen for tenderness, tightness, and rigidity every day, observe the mucus or blood in stool and inform to the doctor immediately, and document passing of flatus in every shift. That is very important. And document the consistency of the stools, the frequency, and the quantity of the stools. Now, indwelling catheters, any catheters that is put inside the body, such as central venous catheters, dialysis catheters, PICC lines, peripheral cannulas, ICDs, endotracheal tubes, tracheostomy tubes, Foley's catheter, lumbar drains, etc., should be taken care of daily. It is important and imperative to do daily assessment for need of continued use and any evidence of infection. And remember to remove your indwelling catheters and follow the CDC guidelines and remove the catheter when it is no longer needed. Now, we all know that catheter-associated urinary tract infections and CLABSI, that is catheter-associated bloodstream infections, are becoming a major cause of concern. So your central lines, your Foley should be removed as early as possible when they are no longer needed. So what is the nurse's role? They should document correctly the day of indwelling catheters and should be able to guide and talk with the residents or the doctors regarding the continued need of indwelling catheters, and catheter sites should be assessed for redness, swelling, and pus, etc. And the handling of these indwelling catheters should be in accordance to the CDC guidelines, and strict hand hygiene and sterile precautions are needed by the nurses all the time. Now, de-escalation of antibiotics, again, this is not just the responsibility of doctors, but as we know, there is a rising threat of multi-drug resistant bacteria. Therefore, it is the responsibility of every healthcare member to prevent excess use of antibiotics so as to prevent emergence of resistance. And already most hospitals, they have a hospital antibiotic stewardship program in order to cut down and restrict the use of antibiotics, and also an infection control committee in order to regulate the optimal use and prompt de-escalation. And the nursing staff should be cooperating regularly with these programs and teams of the hospital. Now, this was all about fast HUGS BIDs, but there are newer advances, there are newer care plans which incorporate more bundles of care, such as fast HUGS BIDS PME, where S is for pressure source, P is for regular positioning, M is for morning or mouth care, and E is for eye care. Then another important one is fast HUGS in beds, please, Danish Bug Fest, and fast hug babies tug. So there are different kind of different variations of the fast HUGS mnemonics, and you should incorporate one of them regularly in your daily plan and in daily shifts. Now, to summarize, fast HUGS BID should be the standard of care in every critical care ICU. and it doesn't cost anything. So it is an inexpensive decision-making tool. It helps and guide even the junior most nursing staff because they have a standardized plan in care that they can follow, and also helps in relieving stress and burden from the senior nursing staff. It helps to improve overall quality and patient outcome. And there have been numerous studies which have shown that actually a properly followed fast HUGS BID plan has significantly helped reduce the rates of ventilator-associated pneumonia. Now, having finished with the essential of fast HUGS BID, I request all of you to unmute your video. A few questions for you, and they are based on the talk itself. So by now, who coined the term fast HUGS BID? So I think everybody knows that the term fast HUGS BID was coined first by Professor J.L. Vincent. Then what are the feeding goals of patients in ICU? Again, remember the feeding goals in ICU are 25 kilocalorie per kg per day of ideal body weight. If you have the facility of indirect calorimetry, nothing like that. The carbohydrate should be 60 to 70%, and fat should comprise 30 to 40% of the total calories given to the patient, and protein should be around 1.2 to 2 gram per kg per day. This is in accordance with the SPEN guidelines. Then, what are the common tools to assess pain in ICU? The common tools are visual analog scale and the critical pain observation tool, and also behavioral pain scale. Remember, you have to use either one or two of these tools to measure pain scale correctly, and it should be part of regular nursing documentation. Now, common tools to assess sedation levels in ICU. The common tools to assess sedation levels in ICU are the Glasgow Coma Scale, or GCS, which is a 15-point scale, and the Richmond Agitation Sedation Scale, which ranges from +4 to -5. Remember again to incorporate and monitor GCS or RASS levels, and that should be well documented in each shift. Now, what should be the goal of ideal blood sugar levels in ICU? As I said earlier, the blood sugar levels are not that stringent. You have to keep a non-tight sugar level. And I can see some people are giving the answers through chat box, and that is very encouraging. Good to hear. Yes, Shrinu, you are right. The sugar levels is 120 to 180 milligram per deciliter. Hiral, you have also answered correctly. Somebody prior to this correctly told about the sedation scale that we should be using. It is RASS. We all know that in 2001, there was a trial which was published in NEJM. It was published by Van de Berg, who actually advocated tight sugar control, that is 80 to 120 milligram per deciliter, citing that hyperglycemia was dangerous in ICU. But later on trials, particularly the NICE sugar trial, proved that hypoglycemia is as dangerous as hyperglycememia. And when we were subjecting the patient to very tight blood sugar monitoring, that is 80 to 120, it was leading to catastrophic incidences of hypoglycemia. And subsequently, we shifted our gear plan. We shifted to 120 to 180 milligram per deciliter level in ICU. And this is a good bargain. It neither allows hyperglycemia and nor does it cause hypoglycemia to the patient. Yes, another one has answered the question correctly. So this was all about the fast HUGS BID treatment plan. Call it a care bundle, call it a mnemonic, whatever. But remember to follow such care plan in order to have a standard protocol based and excellent nursing care plan in your respective ICUs. And this was all about today's topic.
Thank you, Dr. Shikha. It was a very nice, elaborate discussion on faster bits, the VAD prevention bundle as it is known. It contained all details which a nurse should be aware of and how to take care of a patient in ICU, especially those on ventilators. Quite comprehensive, covering all the principles behind it, the monitoring tools also. There is one question in the chat box, which is from Brahma Rama. What is the role of OHS in causing hypoglycemia and role of nurse, if you can elaborate?
So, as I said earlier, that giving oral hypoglycemic agents is not a good choice in critically ill patients. There are a variety of reasons for that. If you are giving OHA to the patient and your patient is having hemodynamic compromise, if the blood pressure level is not great, then in that case, your OHA may not be sufficient. It may give rise to unpredictable blood sugar levels. The OHA that you give may not be absorbed well, because whenever the patient is in hypotension, the blood supply to the gut is hindered. Secondarily, a lot of these patients will not be able to take feed regularly. Their feed plan may be restricted. And giving OHA in these patients can give rise to hypoglycemia. And when that hypoglycemia is going to occur, it is very difficult to predict that. And so in such cases, it is better to give sugar control through an agent where you can monitor it well, where the response is predictable, and where you can see the complications and tackle it early. So initial phases, when a critically ill patient, hypotensive patient comes to you who is suffering from hyperglycemia, either due to diabetic ketoacidosis or stress-related sugar release, you have to give insulin infusions. By the next day, when your patient is hemodynamically stable, you should be able to switch to subcutaneous regular insulin administration. And I will reiterate, giving long-acting subcutaneous insulins or OHA is not a good choice in patients whose hemodynamic status, whose critical status is still shaky. So always prefer insulin over OHA.
We just add on it because we are not very sure about what the amount of feeds or the calories the patient will be receiving and what amount of it will be absorbed by the body. And added on, another issue is most OHAs are a longer acting agent, so we may have periods of hypoglycemia which might be quite dangerous. That is why that's a practice that we tend to avoid OHAs in the patients who are unstable. There is one more hand raised with Anirban. The question I cannot get there. What Abin Roy, what the question is about.
Yes, even I'm not able to view the question.
Yeah. If you can just type on the chat box or unmute and ask your question. I think
somebody is asking.
Okay.
Yes, sir. If we
there's a question about the head and elevation. What if we?
Okay, sir.
What if we have head and elevation of more than 45 degrees?
Sir, I believe that 30 to 45 degree is a good position to achieve. It is a good bargain. It will also prevent, if you do a head elevation more than 45 degree, it can give rise to issues of hypotension. Also, most patients may not be comfortable with the 45 degree position at all times, except when they are feeding and they want to be more awake. So 30 to 45 degrees is the choice of consensus. Sir, if you want to add anything to this, you're welcome.
Yeah. see, the basic principle about it is to prevent what is called a silent aspirations, where we add a gravity gradient. It is thought that the silent aspirations which occur in people, in patients, can be taken care of and that rather will be minimized. So what the studies have done, they have found out that a head angle deviation of 30 to 45 degrees is sufficient to meet this goal. Anything beyond that probably will expose more risk for with regards to perfusion of brain in patients who are hypotensive on one part. Second is if you are at 90-degree up, then some patients may have got compromise or compression of basal part of lungs, which may affect with ventilation. So that is a 30 to 45 degrees is a compromise which has been arrived that it provides optimal control or prevention of aspirations and achieves that in terms of preventing well. There is one more question which has come from, which is that what are nursing interventions in ICUs to prevent constipation? Any evidence-based suggestions if you have?
So there are numerous evidence-based suggestions and time-tested suggestions that can help us alleviate constipation in ICU. First of all, making the patient as well as making the patient ambulatory as soon as it is feasible. A walking patient will definitely have a better bowel habit. So whenever it is feasible, do not take the patient in one position or on the bed at all times. Try to make the patient ambulatory. If you cannot make the patient ambulatory, regular 2-hour posture turning is also a good choice, and also prevent dehydration. Most patients in ICU are dehydrated. Many times patients are given diuretics, and diuretics, they promote dehydration because contraction alkalosis, because water loss. Also, many drugs in ICU, including diuretics, including antipsychotic drugs, they all have hidden anticholinergic activities. And most of us are not aware that how many drugs in ICU may actually be having anticholinergic activity. Due to the anticholinergic activity, the bowel motility is hindered. So whatever drugs that you are giving daily, just screen through them and see that if any of these drugs may be causing constipation. So give good hydration to the patient, give soluble fibers to the patient. Even I have seen surgeons giving sips of warm water to the patient, to any patient who's able to tolerate that. That also help prevents constipation. So all these factors are important, apart from tackling other metabolic causes, like if there is hypokalemia, or if there is a fecolic formation. In that case, you have to do a per rectal evacuation. So all these things are important.
We have got one more question here. Which one is better, kitchen feed or proprietary feed?
Now, it is very difficult to say, but most research, every research has been done on the formula feed. It is time tested. It is more evidence based. If you're talking about evidence, it is most scientific, because, and most all of the nutrition societies, whether it is ASPEN, American Society of Enteral Nutrition, or European Society of Enteral Nutrition, they only give recommendations on formula feeding, how much calories to give, how much protein to give, because we are all aware that in a formula, standardized formula, you can calculate the osmolarity of the feed, the concentration of the feed in a proper manner. You are also able to give the desired number of calories. It is more palatable, different form, and also easily digestible. It is very difficult, almost difficult to replicate the same concentration, the same advantages into the canteen feed. But if, again, in resource limited ICU, sometimes it is very difficult. If there are patients who cannot afford formula feed, then you need to have a good dietitian. You need to have a canteen or a dietary department which can do stringent calorie checking and take care of the osmolality of the feed. And whatever you give, whether you give formula feed or the canteen feed, the idea is to give proper calories, proper volumes, and in correct concentration. But if you talk about evidence, there is very little evidence favoring the canteen feed. Now, there is a question.
I just add on one more thing, that controlling a kitchen where multiple hands are there in preparing the feed is something which is questionable at times.
Less
And
hygienic.
on the other hand, the formula feeds are the one which is corporate driven. So there's a question which is difficult to answer, and it's got all the loopholes open to it. There is one more question regarding thromboprophylactic doses. Does it apply for all the patients, or we can use for certain selected patients?
So, I think I answered about this question in the topic itself, that the requirement of ICU and the nature of it is, somebody can keep the patient, keep the mute button on. Somebody's mute button is off. So, regarding DVT prophylaxis, the nature and the environment is such that almost all of the patient, most of the patient in ICU, they are vulnerable toward deep vein thrombosis, and it should apply to most patients. Of course, there are contraindications if the patient is having a bleeding disorder, or the platelet count is low, or the patient is having a DIC. In those cases, thromboprophylaxis will have to be contraindicated. But whatever that you are doing, if you are giving thromboprophylaxis, if you are not giving thromboprophylaxis, you should document it daily and give the reason for giving or not giving it. That is going to give you medical, because DVT and pulmonary embolism is a major cause of unexpected death in ICU. And as I told, there is a modified Wells criteria. It is a criteria which helps us tell that which patient in ICU is more vulnerable towards developing DVT. So everybody should keep that chart in place. That chart, the criteria, the modified Wells criteria, which is a screening tool, should be there in every hospital's nursing care plan.
I think very well explained this particular point, and that is why most nursing charts have got a screening tool for DVT. Yes. I don't think there is any more question here. If you can just summarize what you have told Dr. Shikha in another maybe 2 or 3 minutes.
So I will briefly summarize. First of all, I would say that nursing care is the pillar of correct and effective ICU management. The job of doctors is important, but the job of nurses is equally important, if not more. And when you are taking care of the patient routinely, it always benefits to have a protocol or a care bundle in place, so that even the newest person will be able to follow that care plan. So, and also by having a documented care plan, it also allows you to do documentation and regular reassessment, that where you are doing well and where you have been failing. So it is my request, and it is highly desirous that all ICUs all over India, they follow some kind of care bundle, whether it is fast HUGS bids or fast HUGS bids me, and then not just to implement it, but also keep auditing your performance every 3 months to see where you are lacking. You have to see that despite giving fast HUG bids me, is there a rise of DVT in your patient, or if after implementing fast HUG bids me, has there been a decrease in incidence of ventilator-associated pneumonia or diarrhea in your patients. And after implementing sedation hold, spontaneous breathing trials, has there been a considerable reduction in the number of ventilator days, in overall ventilator days in patients? So it is important to practice, audit, and then go back and practice again. So these were my last concluding words. I hope all of you enjoyed the seminar.
I'll wait for another minute if there is any question from one of the delegates. If not, the single most, if you can just put in a single most important part of the fast HUG bids towards prevention of that, just single intervention.
I think, sir, all aspects of past hugs debates are very important and they need equal care. The idea is to implement them stringently.
For me, it's ankle feeding and head and elevation. If these two are stuck, probably most other things, uh, they probably are the most important interventions towards prevention of that. I don't see any other question, any other suggestion or comment coming up. Uh, Thank you, Dr. Shikha, for a very elaborate presentation going in details and the principles behind all the practices involved in fast track bids. Thank you all the delegates for taking time and attending and putting up questions and clearing your doubts. And thank you ISCCM for organizing this session and presenting us an opportunity to be part of this program. Thank you all.
Thank you, sir, for your excellent moderation. Thank you, everyone, and take care. Bye-bye. Actually, this is a meeting.